Hello, and welcome to New Ways to Stimulate the Brain for Depression. My name is Jacob, and I'll be in the background answering any WebEx technical questions. If you experience technical difficulty at any time during this WebEx event, please submit your technical issue into the Q&A panel, and I will try to assist you. You may also contact WebEx technical support at 1-866-229-3239 for further assistance. Please note that as an attendee, you are part of a larger audience. However, due to privacy rights, we have chosen not to display the number or list of attendees to everyone on the call today. As a reminder, today's call is being recorded. We will be holding a Q&A session at the conclusion of today's presentation. You may ask an online question at any time throughout the presentation today by simply typing your question into the Q&A panel located on the right-hand side of your screen, or by clicking on the question mark icon located on the floating toolbar in the top or bottom of your screen. Just type your question into the text field and click send. Please keep the send to defaulted to all panelists, and we'll try to answer questions as time allows. With that, we invite you to sit back, relax, and enjoy today's presentation. I would now like to introduce you to your moderator for today, Benita Shobe, the President and CEO of Brain and Behavior Research Foundation. Benita, you now have the floor.
Good afternoon, and welcome. On behalf of our Board of Directors and our many constituents, it is my pleasure to welcome you and to thank you for joining us. This is our final webinar for 2012, and we have the honor of presenting Dr. Mark S. George as our guest speaker today. Dr. George first began studying brain-behavior relationships as an undergraduate student in philosophy at Davidson College in Davidson, North Carolina. He received his medical degree from the Medical University of South Carolina in Charleston, continuing his training there and at the Institute of Neurology in London. Working with fellow Scientific Council member Dr. Robert Post at NIMH, Dr. George was one of the first to use functional imaging to assess brain changes associated with normal emotions and those that occur in depression and mania. Dr. George pioneered the use of Transcranial Magnetic Stimulation, TMS, which was FDA approved in 2008 as an antidepressant. He went on to pioneer another treatment for resistant depression, vagus nerve stimulation, VNS, also FDA approved. He continues to use imaging and non-invasive stimulation, such as TMS or VNS, to understand the brain regions involved in emotional regulation. In addition to his many publications and awards, Dr. George was the recipient of a NARSAD Young Investigator Award in 1996, an Independent Investigator Award in 1998, a Claremont Award, Honorable Mention in 2000, and the NARSAD Falcone Prize for Outstanding Achievement in Affective Disorder Research in 2008. He joined the NARSAD Scientific Council in 2007, and he has also received the World Federation of Societies of Biological Psychiatry Lifetime Achievement Award in 2007. One additional note, Dr. George was recently featured by the U.S. News and World Report as one of 14 pioneers who aren't holding back. Dr. George, it's our pleasure to welcome you, and thank you so very much for all of the wonderful and gracious work you do in collaboration with the Brain and Behavior Research Foundation. Dr. George.
Well, thank you very much. Can everyone hear me? I hope. So I'm here in Charleston, South Carolina, and I have a couple of members of my lab here watching, and this is a real pleasure, and it's a way of me giving back to the Brain Behavior Research Foundation and to people all around the country who are listening in. So I want to talk today really about transcranial magnetic stimulation, this new technology, and talk about its development and specifically the role that the Brain and Behavior Research Foundation, or NARSAD, played in helping us come up with new treatments. Let's see. So before I start, these are the groups that have given money, and you can see at the very top is Brain and Behavior Research Foundation and NARSAD, other foundations, NIH, and I've partnered with industry down through the years to try to advance the technology in this space. From the very beginning, I've tried to make it such that my my pocketbook or my wallet doesn't dictate my scientific answers, and so I don't own any stock or investments in any of these companies. And for the last 10 years, really haven't taken any money from anybody related to TMS because I'm in charge of some NIH or VA studies. So I like to start with this, which is the forgotten half of the truth. When I was a medical student, I kind of learned that the brain was electrochemical, and this is a neuron with a synaptic cleft, and when a neuron fires, chemicals are released, and they go over to the next neuron, and then they determine whether the next neuron fires or not. And we've had a lot of advances in here. This is where fluoxetine or Prozac works. All of our neuropsychopharmacology has been focused here, and drugs are wonderful things, and they can help treat lots of diseases. But what we forgot was that the brain is really electrochemical, and the whole purpose of all of this pharmacology here is really to decide whether electricity gets transmitted or not from one neuron to the next. And the thing that we forgot is the electricity part, and that electricity is the currency of the brain. It's how the brain talks. It's how the brain does its work. The brain is an electrical organ, and all of pharmacology really simply serves to transmit electrical signals to the next neuron. So we forgot that, and now we're rediscovering it with these abilities to get in and electrically stimulate in the brain. This area of brain stimulation is a very fertile one, and it encompasses not just psychiatry, but neurology, neuroscience, neurosurgery. Sometimes we put wires in, cognitive neuroscience, as well as engineering. But it's really in this area of affective disorders or depression where we've had a big clinical impact, which I want to talk about today. So this is a long list of the different ways we can stimulate the brain. At the top are those that are FDA approved, and then below the line here, those that are not FDA approved. So starting here is the grandmother or grandfather of brain stimulation techniques, ECT, TMS, which I'm going to talk about today, and these are the different manufacturers of devices. And then there's deep brain stimulation, which is FDA approved for Parkinson's disease, dystonia, tremor, and OCD. And then there's vagus nerve stimulation, which is FDA approved for both epilepsy or depression. Down below the line, there are lots of new technologies. One thing called transcranial direct current stimulation, TENS units. There's interesting work where you might be able to get people undepressed by putting them into a modified MRI scanner. These are not yet FDA approved, and I don't have time today to go into them, but there's a lot of work of even technologies beyond what I'm going to talk about today. So let me move to the next slide here. Let's see. I'm a little stuck here. Let's see. I need to go. Oh, I think I figured it out. Sorry for the technical problems. Let's see if I can go. Here we go. So those are the promise. The reality is that we only have two Class 1 evidence of treatment. That is ECT, positive randomized trials, and that was done years ago, and then TMS in terms of having convincing Class 1 evidence. So that's where we are. TMS, which is what I'm going to talk about the rest of the day, is a way of actually electrically stimulating the brain without an electrode. So we pass electricity through an electromagnet, and the magnetic field passes unimpeded through the skull and skin, and then it induces an electrical current in the brain. So we're able to actually use the magnetic field as a neat trick to get past the skull and get into the brain and relatively painlessly stimulate the brain in an awake, alert person, which is a really clever trick. Because we can do that, you can use TMS in a variety of ways. You can use it as a research tool where we can actually stimulate the brain and look at the response, what happens in the brain. If we stimulate it at high frequency in a certain area, we can almost kind of temporarily occupy that part of the brain and take it offline. and create a temporary lesion. So if I stimulated the spot in my brain that's involved in talking, I could make myself temporarily speechless. So we can understand brain behavior relationships with the tool, or we can use it as a potential treatment tool where we give multiple stimuli over several days. And that's what I'm talking about today. So why did I think that TMS might work back in 1993? Well, depression is a brain state, and when people come out of it, they go back to normal function. So it's not like Alzheimer's disease or schizophrenia or epilepsy where we think there's a permanent change that's occurring over time. And we had the evidence with ECT that we could reset the brain. So there was a big hint that electrical stimulation might be able to reset the brain in depression. Most people were stuck in terms of with ECT and thinking that we had to have a seizure. And my idea was that no, the seizure was not necessary. There were also, in 1993, ideas that there might be relationships between the cortex and deeper parts of the brain, and that we might be able to, with TMS, stimulate the cortex and then affect the deeper emotional brain. So my first job was as a photographer, and I took pictures, and this was a celebrated picture that was actually on the front page of the New York Times, where we put Washingtonians into a scanner and had them remember their saddest events in their lives. Most of them kind of came to tears. And these are the brain areas. This is the nose here, the back of the brain, and so this would be the right hemisphere. This is the left hemisphere, the nose is here. And these areas in color are actually the brain regions that were activated when people were crying and sad compared to when they were neutral emotion. And so very early on, I was seeing that emotion is regulated in these parts of the brain, and I wondered whether we might be able to non-invasively stimulate it and get people out of a depression. Another way to think about this relationship is, here's a picture of the brain, a cartoon, and we have this big, massive area called the prefrontal cortex. And in health, it actually does a good job of regulating these deeper emotional areas. And in health, we have emotions generating and bubbling up, and then cortex kind of coming to the rescue and saying, no, calm down, in a kind of a parent-child or governing way. And my idea was that depression involves a dysfunction of this kind of regulatory circuit. Here's another way of thinking about that. I have a nice cabin up in the North Carolina mountains not far from here, and I love to go on hikes, and occasionally I'll see this creature here in the woods. And if those of you with good eyes or good computers can see that this is actually a snake, and at this end right here is a rattle. And when I see this snake and this rattle, my limbic system goes crazy. I freeze, I stop, and I want to run away. But then my cortex comes to the rescue, and my cortex says, oh, you're in the North Carolina mountains, and the snakes up here are called timber rattlers, and they never, ever, ever bite humans. You can even step on them, and they won't bite you. Now, if the same snake were in the woods down in Charleston, where I am now by the coast, it would be an eastern diamondback, and it would kill me. And so my cortex has all this information, and my cortex can tell me that I'm in the mountains and that I can stay there and watch this beautiful creature slither away. So anyway, this point is that our cortex is constantly kind of controlling our emotions, and that in depression, that relationship is not working. So with those kinds of ideas, this is the graph of the first patient that Bob Post and I treated with depression, with TMS, back in 1993, actually, in Washington, D.C. And these are the Hamilton scores. So here's a higher score is worse. So you can see she was quite depressed. We started treating her every day. These are days across here. And we got her somewhat better. We stopped. She got worse again, and we started again. She went into a different medication trial here, and then she came back, and we delivered TMS in the way that's being done today, where we treated her every day except for weekends, and then we got her into what's called remitted. So her Hamilton score got better than 10. And then we did a kind of a taper, and she stayed quite well. So this was some of the early evidence that this might actually have a clinical effect. And then we did this study where we treated a group of Washingtonians who were depressed on their way to work in the morning or the evening, and we either gave them active treatment every day or sham treatment, and these are the Hamilton scores, the changes in scores. And so those people who got active treatment, as you can see, their Hamilton scores got somewhat better. They worsened when we cross them over. So this is a picture of myself with my children, and you can see we've caught a nice bass there. And the reaction of my son is the classic one here, where sometimes catching a big fish can be a little scary. And I knew then that I thought I had a big fish. I had a new way of treating depression, and I was so worried that I wouldn't be able to translate it into something that could help a lot of lives. And that's where what was called NARSAD then came to the rescue. And let me, let's see. Although the work was supported by the NIH in the intramural program, it fell quickly out of disfavor, and the program at the NIH was disbanded, and I was told actually that I could do no more work with TMS and that I shouldn't actually talk to the press about it. So it was not only not funded, but it was pretty aggressively not funded. And so I then turned to NARSAD, who funded the studies that you heard Benita Shobe talk about. And it was really that lifeline that NARSAD gave that kept the idea alive. There was no industry because I didn't apply for a patent. And so it took about 10 years for an industry to form and then clinical trials to be done. And I'm really very grateful to NARSAD for having done that. So let's see. I'm trying to get to the right slides, and I apologize that these are truncated up. Well, let's see. So what I wanted to show you was the large NIH study that was eventually funded that is Class 1 evidence. That was at 4 sites, and here in Charleston, at Columbia University in New York, and Atlanta, and Seattle, Washington. And we took medication-free depressed patients and treated them with TMS or sham, and we found that those people who got active TMS had a threefold in rate of improvement greater than the sham, and so that was strongly statistically significant. And so that's really the Class 1 evidence that exists for the disease. Now, let's see. I'm trying to find the correct order of the slides, and I'm just having a real problem here, and I don't know if Jacob can take over and find me the slides that go right after this one. But
yeah, let me go ahead and bring that up here for you. Is this the correct one right here? It goes into the TMS?
Yeah, somehow it's not quite showing correctly, but that's good. Okay, so anyway, it was FDA approved, and it's now out. There's one company that's got a FDA approval. They've sold about 300 machines in the U.S., and I estimate that there are about 16 patients per day now who are getting remission from their depression who hadn't responded to medications. And so it's starting to make a real public health difference. Some new studies that have come out in the last year, sometimes things work in ivory towers, but they don't actually work in the hands of physicians in busy clinics. And there are 2 studies that I'm going to point out here. One by Linda Carpenter, who was the first author of 307 real-world U.S. patients who were medication resistant but stayed on their medicines, sponsored by industry, and they had a 58% response or a 37% remission. And it took people about 3 or 4 weeks to get better. So it seems to be working at a pretty high level in the real world, with about a third of people getting remission and over half getting a response. Another study out of the University of Pennsylvania of their cohort of 100 patients showed about a 50% response and 25% remission. And you have to remember that everybody who goes in for the TMS studies have tried and failed medications. And so these are people who are searching for a new option, and this is providing it for them. The interesting thing is that there are lots of different ways to get into the brain, and there's a stampede now of different companies trying to do this bigger and better. And there's a deep stimulation coil, or multiple coils that will go deep in the brain, or even a very weak coil that might actually be available for home use if it were to prove positive in trials. Let me talk about this company. It's called BrainSway. They're out of Israel, and they've just announced a clinical trial that they did at 21 sites, multi-site, with 233 medication-free depressed patients, where they stimulated largely the left prefrontal cortex. And they found that with active stimulation, they got about 35% remitted, and compared to about 15% with sham, and response rates quite similar. So this is a positive trial, and it's in front of the FDA, and this company as well is hoping to get approval to go to market and be able to sell this to psychiatrists. So the story is moving along with new technology. Some of the work that we're doing here and is going on also around the world is trying to figure out how to make it better. And two candidate ways are increasing the dose or giving more stimulation in a day. Let me quickly show you about this approach of accelerating or giving people many more treatments in a day than we first started. Was initially thought about by Paul Holzheimer and Bill McDonald over in Atlanta, and they did this study in 14 treatment-resistant depressed patients in a hospital, where they gave them 15 sessions over 2 days. So they essentially gave 3 weeks in 2 days, and they found a very good and rapid response. It was an open-label study, so it's not double-blind. We're doing a double-blind study across the street here in the Charleston, VA, where we're taking patients who are admitted for suicidality, and we're giving them 18,000 stimuli in a day or 54,000 stimuli in 3 days, which is about, again, 2 weeks in 3 days. And these are data from those patients. We've done around 21 patients so far, and we asked them before we start stimulating, I'm currently bothered by thoughts of suicide, and then they mark 100 if they really are, or 0 if they're not. And so these are all the patients, and then this is 3 days later after they've gotten 3 days of treatment, and you can see that we're not making anybody worse. A lot of people are better. Half of these people got fake TMS, so we don't know which ones they are, but at least it appears feasible and safe, and we hope to unblind this early next year and potentially put out a potential treatment for suicidality. So we've got a new treatment now that fits. It's FDA approved, and we try people with medications and talking therapy. When that doesn't work, we introduce things like TMS, and then we're starting to develop kind of a staging approach where, depending on how tough to treat your depression is, we'll go with ever more aggressive attempts at getting you better. And we don't give up, and we're trying to get everybody into the state of remission. So this is the group here in Charleston. I have a mustache, as you can see here, and one day everybody showed up mustachioed, and I'm grateful to everybody here who's doing all the work that I talked about, as well as my mentors. This is Mike Trimble in London, who introduced me to TMS, Bob Post, who's active with the Brain Behavior Research Foundation, and Harold Sackheim. And up at that cabin, sometimes I go to try to get away from my work and clear my brain, and one frozen morning I woke up and my pond had neurons in it, and it tells me that the world wants me to continue to keep focusing on this work. So with that, I'll stop and thank you, and I can take questions. I think you have to type those in, and then Benita is going to try to referee those.
Thank you. I see the neurons. That's really a good observation in your water, in your lake. We've got a couple of questions that have come in. Thank you so much. I think technology is just very interesting for all of us, and a little curious about side effects. Are there any side effects that have been noted in your trials?
Yeah, so the question is about side effects. I'm sorry I went through it so fast. it's remarkably well tolerated, and we have the studies show between 80 and 90% of people who start the trials end up getting what the dose is that we recommend. So very little dropout. You have to sit in a chair, and it does, and we stimulate your prefrontal cortex. So there's no IVs, there's no, you're not put to sleep. It is a little bit uncomfortable when it's stimulating your scalp. I describe it as kind of a woodpecker or a tapping on the head, but it's compared to the pain of depression, easily tolerated by almost everyone. And people get used to the discomfort. And that really is the main side effect. Some people get a mild headache, but there really is no negative cognitive side effects, so people are able to leave a treatment and go straight to work, go to a soccer practice, go do whatever they'd like to do with really no problems. And that's quite different from the treatment that's like this, electroconvulsive therapy, where you are put to sleep. There is a potential cognitive problem in terms of memory. Because it's just focal in the brain, there's no systemic side effects. So unlike medications, there are no sexual side effects. There's no drug-drug interaction. So the side effect profile for TMS is really interesting and so far pretty benign.
So you stated, I believe, that this is for treatment-resistant depression, and folks most often try this, or even ECT after meds, have not been successful. Must that be the case, since some people are not tolerant at all of medication, of drugs? Are there opportunities to try TMS before having tried certain medications?
Yeah, so all the studies have been done in patients who've tried and failed medications, and that's the FDA indication. However, trying and failing is different to different people, and some people try but they run into side effects, so they're not treatment resistant, but they're treatment intolerant. And TMS certainly seems like an option in those individuals, and we have good success when we treat those patients. They tend to be able to tolerate this and not the medications. Okay. Moving it up even earlier, could you use it for a first episode depression?
Okay.
You probably could. There's not much scientific information. We would think that it would work, but there's not a lot of data. It's just a pain to actually have to come to a doctor's office and sit in the chair, 5 days a week for 3 or 4 weeks. And so medications and talking therapy really are more efficient, or less costly in terms of time and effort. And so it's not being used frontline because of those issues, but probably would work. But it's not FDA approved for that.
And is it indicated for bipolar disorder as well as depression? And is it indicated for schizophrenia?
So for bipolar disorder, it's not indicated. The patients in the trials were all unipolar depression. As you may know, bipolar depression is tougher to treat and study because people sometimes get spontaneously better. There's the question of what to do in terms of mood stabilizers. So it's harder to study. So the studies have not been done in bipolar depression. There's currently one underway, sponsored by BrainsWay. They're trying to see if their device works for bipolar depression, and that study hopefully will be out in a year or two. So scientifically, we don't have much evidence. Clinically, I have used it in bipolar patients, and it works quite well, actually. Bipolar patients tend to respond more rapidly, so instead of 3 or 4 weeks, they often will get better in 2. And then in some bipolar patients, I've used it in a maintenance way where when they're about to slip into a new episode of depression, they come in for a day or two of TMS, and we can sometimes abort what likely would have been a full-blown major depressive episode. So I'm convinced that clinically it does have a use. However, scientifically, we don't have the evidence yet.
Okay, we're getting a lot of...
And your question for schizophrenia, it doesn't appear to work for schizophrenia. Ralph Hoffman and colleagues at Yale have taken patients with chronic auditory hallucinations and have stimulated over a part of the brain, kind of back behind the ear, that's involved in hearing. And he's found that he can actually reduce the self-report of auditory hallucinations in patients. However, it doesn't appear to last for very long, and so clinically it hasn't evolved yet into a therapy for schizophrenia.
Okay, and that was actually one of the questions for depression. How long does each session last? And then what about maintenance?
Yeah, so each session is about 30 minutes of stimulation, maybe 40 minutes. We tend to be able to get people in and out of our building in less than an hour. And so it's it takes a little bit of time every day. And we don't treat on weekends, although no one's done a study about whether that would accelerate the course or not. Now, in terms of durability, what do we do after we get people better? And we just don't have good answers yet. Typically, if patients are off of medications, I sometimes recommend that they go back on just as an insurance policy. However, and we did that in the NIH-sponsored study, the TMS trial. In 50 patients that were remitted at 3 months, we still had 95% of those patients still remitted. And so it looks like the effects, once they are gotten, are maintained, or at least durable, at least as good as ECT and medications. Maybe better, but we haven't done any head-to-head trials. 5 of the patients in that study looked me in the eye and said, "You're crazy. The medicines didn't work. This thing worked. I'm not going to go back on the medicines." And so they didn't go back on medicines. All 5 of those patients were well at 6 months. So we really don't have the answer of whether what to do after people get better with TMS, whether to advise them to go back on medicines or to use maintenance TMS. And people are experimenting with different protocols, but it's an area where we need more information and more study.
Have you followed patients long enough to know whether or not there are any long-term memory deficits?
Well, I think I'm probably one of the people on the planet who's got the longest exposure. And other than hair loss and a little bit of orneriness, I don't think there's any side effect.
Okay.
We have followed patients who've been treated in those early studies. Margaret Brender, the first patient, and there haven't been to date any long-term consequences. And we've done animal studies and looked at long-term sequelae. So it looks as if there doesn't appear to be anything that would happen long-term. But you never know. And the technology is obviously powerful enough to treat, so it could be powerful enough to harm. So we have to keep looking. But to date so far, knock on wood, things look quite good.
A couple of our participants, excuse me, would like to know if there are any gender differences, and have you been able to use this with children? What are the age ramifications? So
far there's no differences by gender in all of the industry trials. Our NIH trial, both men and women tend to respond well. The negative response predictors, who doesn't do well with this, if people have high comorbid anxiety or comorbid OCD, that tends to be a relative non-response predictor. They don't respond at the same high levels of the slides I showed you. If they've been ill for many years, say a decade or two, their chances of responding are less than somebody who's been in an episode a shorter period of time. So comorbid anxiety and the length of episode tend to be negative response predictors, but gender doesn't. Now, in terms of the issue about kids, first, do no harm, and this is a new technology that looks safe, but there really haven't been lots of studies in anybody under 21. There is a study ongoing now at Mayo and in teenage depression. No one that I know of has gone below puberty in terms of using the technology. So people are going quite slow in terms of using it in children, although there are some studies underway.
So then, as we might expect, there's several questions about cost and availability and insurance coverage and what markets, Chicago, Boston, where is this technology available, accessible? Insurance coverage, cost. One person said that in Chicago they investigated it and the cost was $400 per session. So I guess that's not an insurance issue, but it's a cost per session issue. Any guidance?
Yeah, so I'm a pretty good scientist, a very lucky scientist, an okay doc. I'm not very good at business at all, and it's really kind of shocked me that we've done the hard science work to show efficacy and that there's now this second battle about payment that I just assumed the science would sway, and it hasn't, although it is. So there really is a battle going on. Some insurance companies are paying. Federal Blue Cross Blue Shield, Anthem Blue Cross Blue Shield, which covers 27 million lives, just announced a coverage policy. So slowly but surely, some of the larger insurance companies are starting to pay. There's a real battle with Medicare, and there are some parts of the country, the Northeast, Massachusetts, the Mid-Atlantic, Ironically, Alabama, Tennessee, but not South Carolina, where I am, covers it with Medicare. So those decisions are being made now, and I think they're evolving. I'm hopeful that it works, and it works in people who need a treatment, and that our healthcare system will eventually come around to paying for it. It's inefficient now. I mean, you have to come and sit in the chair for an hour a day for 3 or 4 weeks, and that's a lot of time and effort. And so part of the push to try to do it quicker and faster would be that we could get people well in a couple of days, and that might make it overall less costly and allow it to be picked up more quickly. In terms of the actual cost per place, it is in that range that I've seen. The least expensive, maybe $200 a session, sometimes up much higher. So you have to kind of say, is that worth it? The cost for a course of ECT, which would be the next best option, is clearly much, much greater than those numbers. Usually we say around $5,000 to $10,000, including the anesthesiologist and all the cost. So it's less expensive likely than ECT, but more expensive than medications. But if we can get people remitted, they can get back on their life, and then you have to say, what's the cost of that?
Okay.
So I wish the answer were better there, but it is evolving, and I think as other companies get FDA approval, there'll be more people who will be going and talking to the insurance companies and saying, hey, we're also gathering longer-term data, cost-effectiveness data. We're doing a study at the VA where we're treating people with TMS to see if it works in veterans, and then we're actually looking at how much health care they use in the next 6 months. Does getting better with this technology save money in terms of admissions to hospital or visits to doctors? And so we're trying to generate the money that might make it, the information that might make it understandable to insurance companies about why they should pay for it.
Okay, I have a question that may be from a professional. Let me see if I can find it. What do you view as the most important research questions about neuromodulation that investigators should pursue?
Well, that's a tough question.
Oh.
I suppose the basic one, the one that as a scientist still gets me going is, what are we doing? How is it that we're, I have this idea that we're resetting this cortical system. How is it that we're resetting it? Why would stimulating and tickling the circuit cause changes? So what are we actually doing to that circuit? Are we changing the wiring of the brain? Are we changing the dendritic sprouting? How is it that we're actually resetting this governance? And I think if we knew that, then we would probably be able to reverse engineer things and come up with the most efficient way to actually get that system reset. And so maybe make things like TMS much less expensive, much more efficient in terms of how to do it, in terms of the rhythm or the pattern of stimulation or the location. So I suppose the most important fundamental question is still that one of mechanism. What is it that we're doing when we get people better with this in terms of resetting that circuit?
That was actually one of the questions. What's the hypothesis to whatever? Excuse me, I'm getting a sore throat. But what actually happens that triggers the effective response?
Well, we don't know. There's a group in Belgium who've actually done serotonin SPECT scans and shown that we're actually causing changes in serotonin transmitters in those parts of the brain. So it integrates with knowledge of what we've done with pharmacology for all these years. But in terms of the actual neurobiologic changes, we just don't know. That doesn't stop us from using it as a treatment. We've not understood how ECT works, and yet it's our most effective treatment and a lifesaver that we've used for 80 years now. And so not knowing the answer shouldn't stop us, but it sure would be nice if we could understand it. And that's why foundations like the BBRF are so important. If we can get that basic knowledge, it really could have kind of exploding effects in terms of helping us come up with even better treatments than this. I've talked about TMS because it's a nice story and it's the one that I've been involved with. But my hope really is that TMS is just a bridging technology, that if we can get this basic question answered, that I would love, for 20 years from now, nobody be using TMS in the way that we're using it now, and that we've evolved into using some other form of brain stimulation that is much more effective and could produce remissions and even cures. So I'm hoping that our work now is but a stepping stone in an ever-evolving understanding.
Well, how nice to use the word cure, to hear the word cure. We seldom hear anyone even broach that. But speaking of the future, given your description of the time commitment and perhaps a little bit of the discomfort required, do you see in the future the possibility that this is actual home treatment, that someone could actually self-administer this type of
treatment? So the issue of home treatment is a really interesting one. Right now, one of the side effects I didn't talk about is that you can accidentally cause a seizure, and there have been maybe 30 seizures accidentally caused by TMS over the world's use with the technology. And so you obviously don't want to be sending something home with people that could cause a seizure. And so if we could find ways of stimulation that are far away from those that cause a seizure, that might allow home use. There's this one technology called by a company called NeoSync, where they actually use very weak magnets, but they spin at the brain's stimulation frequency. So their attempt there is to use a weak approach, a real weak TMS that wouldn't make your thumb move, but in a resonant way with your own brain that would reset. And they're doing a clinical trial now. If that trial were positive, then I think some form of home TMS would be right around the corner and probably available in 3 or 4 years. So it's definitely within the realm of possible, but there are issues of safety and then really the power of the device needed and whether that could be used at home. But people are working on it right away today.
Well, one of our participants has a device that attaches to earlobes and it pulsates, and I think it's called vagal, V-A-G-A-L, stimulation. He's wondering if that's effective. He hasn't used it in a while.
So on that slide a while back where I kind of showed this list that actually ran off the page, I'm an open-minded skeptic. So you have to be open to the fact that we don't really understand the brain and that there may be things that work, but you have to be skeptical. You trust them only after you do the hard science to show whether they work compared to sham. And so there are a lot of devices out there, stimulation devices, that could work, but for which the evidence is really not there yet. And I think this person that you're describing has one of those. And there are several devices that do attach to the earlobes and do send current through the brain that way. One of those was actually grandfathered into FDA approval back in the 60s, and so is around and able to be sold. They haven't undergone the same kind of level of rigorous trials where I can say that we have Class 1 evidence that they work, although they might. But again, if they're powerful enough to treat, they could be powerful enough to harm, and so I would urge people to be cautious about them, but open-minded, and we just need to do the science to settle the issue. And right now, there are a lot more people out there trying to sell these devices than are putting money behind studies.
Okay. And I guess that's probably wrapping it up, except other people are still asking about OCD, about PTSD. Is anyone doing any further research with this? And schizophrenia. And yes, there will be a transcript. Someone did ask that. And then what guidance would you give anyone, Dr. George, about finding a location for administering TMS?
Well, there's a lot of questions. So OCD, there are a couple of studies. I did one of the first ones with Ben Greenberg years ago back at the NIH, and we found a single session of TMS over the right orbitofrontal area could temporarily knock down people's obsessions and compulsions. The clinical trials to date have been rather disappointing, although it appears that you can actually have an anti-obsessional effect with a dose of TMS. We have some people who have both OCD and depression, and a not uncommon story is that they come in, we work in a conventional way, and we can get rid of their depression, but their OCD persists, and then we will go over and stimulate a different part of their brain, and they find that they feel temporarily better, but it doesn't last more than a day or so, and then they almost get addicted to the sessions, and that's not a viable long-term solution, and that happens a lot, actually. There's one study where they stimulate a different part of the brain called the supplemental motor area, kind of in the middle of the brain, right in front of the motor cortex, and there do appear to be some clinical effects with stimulation there, although I don't really have any clinical experience. So it's still under investigation for OCD. For PTSD, there's a nice study out of Israel where they took patients with PTSD and had them relive their trauma, and then right after they relived their trauma, they stimulated over parts of the brain involved in emotion regulation. And they found a very good effect of treating PTSD with TMS when they kind of combined it with exposure therapy. And we're doing a similar trial at the VA here, and we've treated about 10 patients in a blind study, and it appears to be tolerable. So I'm quite optimistic that eventually we might be able to use it for PTSD. For schizophrenia, we can use it if there's a mood component, a depression within a schizophrenia, and that seems to work. And then there's the work with hallucinations. But other than that, this technology or these technologies really haven't been able to impact much in schizophrenia. In terms of finding a provider, there's the one company who has FDA approval, Neuronetics, and they have a website, and they can hook you up with someone locally who has one of their machines. Doctors are able to use non-Neuronetics machines, and there are some providers out there who aren't on the Neuronetics list, and so you could do kind of a Google search nearby. It's almost the case now that most major medical centers will have someone there who's using some form of TMS. And if they're not using it, they would likely know someone nearby who does. So you could give a local place a call.
Dr. George, I think that you addressed this question, but let me ask it one more time. What do you think about the data suggesting that you can treat only 3 days per week, given the time burden on patients? That question popped up a couple of times since you addressed it, so maybe one more time.
Yeah, so what we did in the pivotal studies was treat 5 days a week with weekends off for 4 to 6 weeks, and that seems to work. So everybody wants to know what the critical elements of that are, and perhaps whether you can just treat 3 times a week or 5 treatments on 2 days, and we don't know. We really don't know. Those things haven't been rigorously explored, and sometimes when it doesn't work for patients, we do just treat 3 times a week, and we sometimes get good clinical results. And so, again, we just don't have good evidence that those other treatment regimens do work, but I in our center here, do we do that for people who have to drive from out of town? Yes, we'll try to double up 2 treatments on one day and then skip a Friday so that they might be able to travel in and out. And we do get good effects with that, but they just haven't been rigorously studied. We proposed such a study to the NIH several years ago, what we called a cluster study, where we were going to test 5 days a week versus 3 days a week. And guess what? It was not funded. So we don't know the answer. But it's reasonable. And if that's all that you can do, there's no good data that it's critical to do 5 days a week. And so, if that's all that you can do, you'd give it a try.
And you've been very generous with your time, but I think there's one last question that I'd like to pose from one of our participants. Is there evidence that TMS expedites recovery from depression when used along with antidepressants in freshly diagnosed patients?
So the question is there evidence that TMS treats depression in freshly diagnosed
expedites recovery.
Can you use it as an augmenting thing? So, yeah, some people have said, well, what if you start medications, they often take sometimes 3 to 4 weeks, and maybe you could get a boost with TMS early on. I'm not aware of any early adjunctive studies showing that. If you do TMS plus medications, you can get people on their feet back in their game quicker and better. And those are tough studies to do because you have to show an effect of the TMS on top of the effect of the medication. And in new onset non-treatment resistant depression, placebo responses can be very high, 50%. So the sample size of a study like that is generally 1,000 patients. So those are hard studies to do to show an augmentative effect. So the answer, are there scientific data? No, I don't think so. Not that I'm aware of. Would I do such a thing clinically? Yeah, there sure would. Although it really does often take 2 to 3 weeks for the TMS effect to begin as well. So although it does appear faster than antidepressants, it's not in non-bipolar patients terribly rapid.
So, Dr. George, as we're closing, one of our participants has asked that you show one slide in particular again, the staging slide. Does that sound... You know which one that is?
Yeah, this one. Can you see me?
The treatment, yes.
Yeah, there's the slide again. So what I'm just saying here is that, we shouldn't be content for people to live lives of misery trying 7 medications and not responding, and that what we ought to do is think creatively if people don't get remitted, and that it should be our goal, remission, back on the game with the first medication, then switch to a second, and if they're not back on their game, don't allow and tolerate partial responses, and that we should then be aggressive in our treatment of depression and perhaps employ TMS is where I put this here. There's this other technology, TDCS, we didn't have time to talk about, and there's a big study about to come out in the archives of psychiatry showing that might actually be helpful in this level of depression here. And then for people who don't respond to TMS, and as you can see from those slides, that is easily maybe a third of the patients, that we again don't tolerate terrible lifelong depression, and that we go on to ECT or even other things that are investigational like DBS.
Okay. We're getting very nice thank yous from our participants for your generous time and in particular for taking so much time with us and answering just about a lot of questions. Yes, the last one, so generous. Thank you very much.
Well, thank you all, and yeah, this is great. And thanks to the Brain Behavior Research Foundation for the lifeline of this technology back in the day. And I think the same is probably happening all along with other technologies out there, and it's so critical, the foundation. So I'm very grateful to be able to give it back. I'm also grateful to the members of my lab who've been sitting here in my office and not being able to hear the questions.
Well, I think we have a transcript that they'll be able to read.
All righty. Well, thank you so much. Bye-bye.
And we'll have that posted as soon as we possibly can. So thank you, Dr. George.
All righty.
And for all
Bye-bye.
of you who have joined us in our today's webinar, we hope you'll extend your support to the Brain and Behavior Research Foundation to fund more research like that Dr. George has presented and at other institutions with the single goal of achieving advancements and more breakthroughs in support of you and your families. You will receive an email from us to that effect, and we hope that you will please consider a gift. And then one last thing, for those of you in the New York City area, on Friday, October 26th, I invite you to join us for the 24th Annual New York City Mental Health Research Symposium for listening to award-winning professionals in the field like Dr. George. And those presentations are also followed by a Q&A, and those presentations will also be available by transcript. But you can look at our website, www.bbrfoundation.org, to learn more. And thank you again so very much. Dr. George, you're a jewel. Thank you. Goodbye, everyone.